Hello, hello, hello. We are live now.
Yes, I'll start.
Hello, we are live now.
Okay, fine.
Your voice is breaking. Hello.
My voice is breaking.
Yeah, yeah, yes, yes.
Yeah, yeah.
Your voice is breaking.
Oh, I don't know. There may be some net problem here, in the hospital. Okay, उसको पता है? कैसे? Can you hear me now?
Yes, yes. You're audible.
Okay.
Now again the voice is breaking.
Voice is breaking again.
Yeah, yeah. The voice is breaking again.
So there's some problem in the net, that's a problem. So I don't know how to solve that. So now is it audible?
Voice is audible, but it is breaking suddenly. It is breaking from middle.
That's actually, I think, a net problem, मुझे ही जाना चाहिए वहाँ पर रूम में ना वो है.
We can just try changing the place where you can find a better net bandwidth.
Okay, guys, fine. I go to the room.
Sorry.
I'll go to other and
Oh, okay, madam. Okay, okay, okay. No problem. Okay.
I'll try some other room and try.
Yes, yes,
There is
madam. Yes, yes,
some here.
yes, yes.
कनेक्ट कर दिया वो तो आ रहा है आपका हेलो
Hello.
can you hear me now
Yes, yes, yes. Your voice is audible now. Yes, yes.
I've come to another station now
Okay,
so
okay.
I think it should be better
Yeah, yeah. Yeah, it is much more better than earlier.
okay so yeah so is this going to be an audience oriented or just a talk with that's all
It is going to be just a talk in which
okay
you will be sharing your slides and you will be speaking about the topic.
we are from Sanofi sir so why what I'm saying was that it's just a talk right
Right, right.
okay so now let me just I start sharing my screen
Yes, yes, you can.
so today I'll be talking about thyroid disorder in children and this is basically a thyroid gland is a gland which is found in the like butterfly gland which is found in front of the neck. The basic function of this thyroid gland is to produce thyroid hormones. And these thyroid hormones are very, very important hormones to carry on the basic metabolic function of the body. All the function, in fact, of the body depend on the thyroid hormone. Thyroid. So thyroxine is one of the, production T4, T3, and TS. We'll talk about more about this in the next slides. And here we are focusing mainly that the thyroid gland is very, very important structure. Now the hypothalamic pituitary thyroid axis is basically that seeing that the hypothalamic pituitary thyroid axis, it works in a way that the hypothalamus produces TRH, and then it goes and acts on the thyroid gland to produce TSH, and TSH goes and acts on the thyroid to produce T4 and T3. So when you have excess of T4, T3 in the body, it causes inhibitory inhibition of the release of pituitary TSH and also TI. So what you are doing is basically it's a very good mechanism. It's a very good feeder mechanism which is present in the body. And this, as a result, if you have more thyroid in the body, your immediately thyroid function become better. So they have what are the various thyroid disorder you can see in children. One is a primary hypothyroidism. That's maybe congenital. We'll talk about this in the next few slides. And then there's an autoimmune Hashimoto thyroid, which is you see in the younger adults, like in maybe 8 years, 10 years, 12. Then there's iodine deficiency. Then there's iatrogenic, this is goiter injection and radiation. Then there's a transient transplantal passive antithyroid drugs, maternal transplant antibodies. So these are all the things you can find. Now, the secondary hypothyroidism, it is central hypothyroidism. There's a TSH deficiency. So the TSH deficiency is there and there's a so there's primary hypothyroidism. Hypothyroidism may be autoimmune, grave disease, which you all read about and know about it, that there's something called as a grave disease. Then there's a neonatal grave disease, which may be because of transplacental passive TSH receptor stimulating antibodies. Then there's secondary hypothyroidism, so where there's a TSH. This is very uncommon. So we will focus mainly on hypothyroidism today, and maybe another time we can talk about the other things, other thyroid disorders. So, there. So these thyroid function tests are very, very important. Every pediatric physician, every should understand that the thyroid function tests, these are performed on serum specimen. Either you use manual or automated methods, which use specific antibodies to check the level of T4, level of T3, and TSH. TS is the most sensitive indicator of thyroid function, except when pituitary disease is suspected. So the most sensitive indicator of thyroid function is expect when pituitary disease is suspected. FT4 estimate may be done. So you may do an FT4 if you require it, but TSM is very good. So there are certain called thyroid antibodies, TPO, antithyroid peroxide antibodies, and thyroglobulin antibodies. These is many times to be sure to know the etiology of the disease. If this is positive, that means it's an autoimmune thyroid cause or autoimmune thyroiditis or autoimmune Hashimoto thyroiditis. Then a scan is very, very helpful. So we're talking about, what are the various thyroid function tests. So the thyroid function test, which is most helpful, thyroid function test, besides this is a thyroid scan. So if you want to differentiate between subacute thyroid and grave disease, it's very helpful. And you can also pick up hot nodule called neuralism. Ultrasonography, it is to evaluate where you have suspicious structure thyroid abnormalities. So ultrasonography is done for that. to pick up the thyroid abnormalities. Now, various thyroid function tests, TSH 0.4 to 5, FT4 9.1. This is a normal range, I'm just telling you. FT4 9.1 to 3 is picomoles, FT3 in some. So in your lab, some lab may show picomoles, some lab may show in microgram per deciliter. So here you have, the next second is 0. TS 0.3 to 0.5, T4 4.55, FT4 0.28 nanogram. So remember one thing, that whatever you lab you take, you see the value of that and compare with the value of that lab, and then only you make a decision, okay, that this patient is having hypo or is having subclinical hypo, what is he having. Now, there's a term, let's go for a small, quick case. There's a case of a 3 kg single male child which was delivered by normal vaginal delivery, hemodynamic absolutely stable. There's nothing in the family history. There's no history of any medication taken by the mother during pregnancy or before pregnancy. The dried blood sample, this is a paper, filter paper. You take a filter paper, you take a sample on that. So very common to do all the analysis, especially, you do the neonatal screening on the base filter. So DBS TSH was 20. It was sent on day 1 and the repeat on day 7. The TSH was 17. So FT4 is 1.01 nanogram per. So that's why what we find from all this is that on the day 7, the TSH is 17 and FT4 is 1. So what you have found is that there is still a fall of TSH, but it is still on the higher side. So what should you do in this patient? That's the next question. The FT4 is normal. So we'll talk about this in the next slides. So first, what is congenital hypothyroidism? When should you suspect congenital hypothyroidism? When there is prolonged jaundice, if the baby is prolonged jaundice, if the baby has constipation, if the baby has coscame, if the baby has umbilical hernia. So this is what you are saying. So basically, for any baby, we have a cutoff of TSH of, we take it as a TSH of 20. And if the TSH is more than 20 in a baby with newborn, when you've taken a cord blood or if you've taken a sample, then you should recall the baby to confirm, if you've taken dried blood sample, to confirm whether this is congenital hypothyroidism. So therefore, this is quite reasonable specificity and sensitivity is there. And that's why TSH of 20 is taken. Now, this is a very nice scenarios. If suppose a baby is born and he has a TSH of 80, more than 80, this is highly suspicious of congenital hypothyroidism. So send a confirmatory sample. If you've taken a dried blood sample, send a confirmatory sample and commence therapy without waiting for what the results come. If the TSH is more than 40, call the baby back after 72 hours and then do a confirmatory venous sampling and then see. If the TSH is between 20 to 40, then you recall between 7 to 10 days for repeat. Okay, so you have done it after 40, then you have done 20 to 40 and recall after 7 to 10 days for repeat to see what's happening. So that's why it's important that you should, so what is happening? So recall after 7 to 10 days. So now what do you mean by congenital? Congenital, I mean the baby is born with hypothyroidism issue. Now, if the TS is more than 20 before 2 weeks of age, so this indicates congenital hypothyroidism. If the TSH is greater than 10 after 2 weeks of age, then it is hypothyroidism. So remember this. Baby after 2 weeks, TSH is more than 20, if baby after 2 weeks, more than 10 TSH, congenital hypothyroidism. Or even if you have a TSH normal, but FT4 is less than 1.7 nanogram per deciliter, or the total T4 is less than 10 microgram per deciliter, this is indicative of congenital hypothyroidism. So remember these things. This is very important to know the cutoffs where you will label this as a congenital, because it's very common. Physicians are so much confused, pediatricians so much confused, everybody confused. I'm getting a TSH of 14. Should I start the treatment? Should not start the treatment? So now going back to that case, the case where we had on day 7, the TSH is 17, but we had taken, remember, after 2 weeks, if it persists more than, 20, then we are considered. So therefore, in this case, we need to keep on observing the baby. That's all. So for all newborns, preterm and low birth, very low, they should do a routine screening for hypothyroidism at 48 to 70. We are trying to make it as universal screening for all the babies, but still it is not going on, and we are trying that. But most of the institutions have started doing this thing after hypothyroid screening. So all newborn, preterm, low birth babies should undergo routine screening for congenital 42 or 70. Sick neonates who are sick, who are in the sick nursery and all that, should be at least 7 days age. High risk neonates, ill newborns who are admitted to NICU and multiple births, particularly same-sex twins, may have a second screening at 14 weeks, at 4 weeks away. So you must, in those high sick neonates, at 4 weeks away, and sick neonates, who can be at 7 days. So always in these babies, re-screen again after some days to confirm whether the TS is infected. So what is the criteria for confirmative initiation thyroxine in term newborns? We're talking about term newborns. So if there's a low T4 less than 8 or a low FT4 less than 1.1, what are the value of TSH? You have to start the medicines. Okay, so 1.1 FT4 and a T4 less than 8. If there's a mild low T4, T4 is less than 10, and low FT4 is less than 15 or 1.17. If the TS is more than 20 and less than 2 weeks of age, you must start thyroxine. Okay, so this is one condition with him. Now, then second is normal FT4 TSH with persistently TSH high. So you have a patient, now you start give to get T4 TSH is normal, but TSH is 11. So if it persists beyond 3 weeks of age, the TSH persists to be more than 10 or persists more high, and T4 is normal, then you will start thinking of that this reassess, and just give the medicine and reassess at 3 years. So this is a basic, every information for every child should know who are the babies who need to be screened and how to screen the babies and when to do the thyroid function and what are the cutoff values where you say that you need to start treatment. This is just a big table. This is the same thing which I told you already. So we'll not go through this thing. Now the question comes is that it is very common that I have my patient is having TSF 24. I'm sending him for a scan. So the scan should be performed within 5 days of treatment. That's very, very important. And you should never delay the treatment if you don't have a scan available. Maybe you can do the scan later, but do not waste, start the treatment immediately. But within 5 days of starting, you must do the scan. Why? Because then if you do the treatment and do a scan, uptake will not occur, you will not get a proper result. So that's why, and you can see here that, this is normal, there's uptake, there's no uptake, so this is complete agenesis. There is no tissue at all. Here there's ectopic thyroid in the second diagram, which you can see here what's happening. The thyroid is not in its normal position, it's a different position. So maybe there will be some TSH increase, but maybe with time you may need thyroxine medicine. And here is a very nice, this is a condition, an 18-month-old baby with a large goiter and increased uptake of technetium secondary to TSH stimulation. So here what is happening? There's increased uptake in the normal position. So here there is inherent defect in thyroxine biosynthesis, dysmonosis, or excessive exposure. So all of these this is telling us that this patient is having excess, this thing, but there's no release into the blood of thyroxine. So therefore the gland is big. You might have a goiter at that time. And when you do it, they'll find there's a defect in the normal position and there's innate biosynthesis defect. So this is called a dyshomogenesis. So here you have seen you can see here very nicely that, this baby, had this baby here is an 18-month-old, a large goiter, increased uptake of technetium. The gland was large and later a gland measure 5. So, but there is no release of thyroxine. So this is interesting. So one must remember the TS is more sensitive for primary hypothyroidism. The free hormone is better than the total thyroid hormones. FT4 is best to diagnose a central hypothyroidism because in central hypothyroidism, you may have FT4 normal. Okay, and then the limited role of free or F or total 3. So there's a very little role of F3 or total T3, right? So this is something you must understand. There is no role of doing a T3 in children with this hypothyroidism. So now next question comes up. It's very common that people do a total T4 and then they find that the results are fallacious. Now why it happens is in a patient with low TBG can occur, low thyroxine binder, because if you do a T4, it is depending on the binding globule. The inpatient with familial, there may be familial, it may be nephrotic syndrome, it may be cirrhosis, maybe they're taking androgen, maybe there's malabsorption, maybe steroids. So all will cause low TBG. So when low TBG is there, you will have a total T4 will be less. But when you do FT4, it is normal. So now you understand why FT4 is better. The same way, you may have a high TBG. High TBG may be because of oral contraceptives, because of pregnancy, because of hepatitis, because of low fibroid or congenital. So there the TBG is high. And then when you do it, you will have high T4. So, but when you do FT4, it's normal. So therefore, T4, FT4 is a better more this as compared to this. This is a table which clearly shows, basically what is more what is TSH is low, TSH is high. So there's primary hyperthyroidism in is a high, and then subclinical hyper TSH secretion. So what we have here is very nicely you can see that this is TSH side and this is FT4 side. So if the TSH is high, the FT4 is low. This is primary hyperthyroidism. If the TSH is okay, and the this FT4 is on the lower side, it may be just euthyroid sick or maybe a thyroid in transition. And if TSH is normal, FT4 is normal. Nothing to be done. It's just normal. If the FT4 is low and TS is also low, it is likely to be central hypothyroid, or it may be a sick thyroid, or it may be thyroid in transition. In the same way, if you have FT4 is low but TSH is high, which can happen many times, so this causes subclinical hypothyroidism. You have a normal FT4 and you have a high TSH, so this causes subclinical hypothyroidism. So you may have the same way if you have a low TSH and a normal FT4 is called subclinical hyperthyroidism. And then you have a condition where both, it's very common. A doctor will phone up and say that, sir, uska TSH bhi zyada aa raha hai, aur T4 bhi zyada aa raha hai. So this is inappropriate TSH secretion. If you have a high TSH with high T4, you're having a FT4, that means inappropriate TSH secretion. It may be also a sick thyroid. Sick thyroid, you can have any both these. So sick thyroid can have a lot of issues. It can be high TSH. It can be with a low with a normal T4. It can be a high TSH and a high T4, high FT4. So that is there. So if the TSH is normal and the FT4 is high, now this is another condition. So it is basically a sick thyroid. You understand? So TSH is normal, but FT4 is there. So most likely sick thyroid. So and then you have very, very common a low TSH and a high FT4, which is basically hyperthyroidism. Okay. So this is your way of understanding, and it's a very nice table. Most of the everything of high thyroid is can be on this table, this algorithm. So the TSH secretion is in a variation. It's a dinodal variation. 50% is dilution and daily. So intra-day and intra-resting variation excretion is there. So T4 TSH can be done any time of the day. Remember this. People are always asking, khali pet karna hai, khana nahi khana, thyroid function khali pet karna hai, kaise karna hai. So these things you must know. And in baby, there's nothing like khali pet na. So morning sample liya, after feed liya, because we're giving the tablet of the mother's milk only. So there's nothing like that. But T4 should be done before the drug. Okay. So half-life of TSH is what, 1 week. It's stabilized 6 weeks. So if you have changed a dose of any patient for TSH, or you're given more added thyroxine, please do FT for TSH after 6 weeks because it takes this much time to stabilize. Okay. So stress, lot of stress can cause non-thyroid illness. Lot of stress, any stress, sickness, septicemia, any surgery, any this, you can have non-thyroid illness. So let's come to acquired hypothyroidism. If the TSH is more than 5, if the TSH is more than 5, retest it just to confirm that you have, maybe there's a lab error. Just confirm whether it is okay or not. So you just test it. Lab error is not there. If the TSH is more than 10, you have to treat the patient. I'm talking about acquired hypothyroidism. Now maybe a baby of 4 years, 6 years, 7 years. The TSH is more than 10, you have to treat. If the TSH is between 5 to 10, what do you do then? So TSH is between 5 to 10. Then you do an FT4. So FT4, you see what is happening FT4. Now, if the TSH is between 5 to 10, FT4 is low, FT4 is less, that means it is most probably central hypothyroid. So TSH 5 to 10, low FT4, central hypothyroid. If the TSH is 5 to 10 and FT4 is normal, then you have to, we have to follow up these patients, see them again. Then, see if there's a female child, if the antibody titers are positive, if there's a goiter, follow them up. So like TPO positive, thyromegaly, family history. So these are predisposed. So then you have to just see and follow them up to further up whether they may go into overt hypothyroidism. This subclinical hyper may go into overt. So therefore, this is how it is. So normal, you have this, the indication. Yes, if there is a TPO positive or a big goiter, then you might start the treatment. Otherwise, no treatment is just required, only follow up. Right? So it's a very clear-cut picture of how to go for. Because I have now we're talking about acquired hypothyroidism. The screening protocol is very, very clear. So there's no doubt about it. So more than 10, 5 to 10. If it is low FT4, then central hypothyroidism, treat it. If it is normal FT4, then you just wait. If it is normal FT4 when thyromegaly is there or the TPO or there's family history, then you must treat it. Otherwise, no, just follow up. So this is a very nice, table where it tells everything. So before 2 weeks, if your TS is less than 20, nothing to be done. If 2 to 6 weeks, if the TS is up to 10, nothing to be done. After 6 weeks, it's just like adult value, 0.5 to 5. So you have to treat the patient. You have to treat the child. So this is what is very important to understand. So this is something which give you this, and the FT values are in picomoles, then 15, 34 picomoles, 10 to 20 picomoles, 9, 20 picomoles. This is something which people should know, and that's very easy. So you should have it in your clinics, and you can just keep it on your table, and then with it, you can write. So we'll just go one or two cases before we close up, before we close the whole session. So we'll have a question answer after. Baby delivered by patient X was 3 days old and 3.2 kg apparently normal. Neonatal examination is normal. Neonatal screening for thyroid function there, third day is TH is 57, FT4 is 0.5. So what dose? So we know the TH is 57. Baby 3 days old. And we already told any baby who has more than 20 within the first 2 weeks has to be treated. So this is TH is 57, quite a FT4 is 0.5. So what dose of thyroxine should be started for this baby? So we start normally with a dose of 10 to 15 micro per kg per bed. This is what the American Academy have, mentioned. So if the baby is 4 to 6 months, 8 to 10 micro, if the baby is 7 to 12 months, 6 to 8 micro, 1 to 5 years, 5 to 6 micro, 6 to 12 years, 4 to 5 micro, greater than 12 years, pivoting grade 2 to 3 micro, greater than 12 years, pivoting grade 1 to 7 micro. The thyroid scan should be done for this patient to find out how to treat. Okay, the scan should be performed within 5 days of starting therapy. So within 5 days of starting therapy, you should start the scan. The treatment can be delayed waiting for the scan. Ultrasound is a better alternative than scan. So now the question is, what should be done if you're doing a thyroid scan? So as I already told you that you should try to do a scan within 5 days of starting treatment. So this is the answer to this. Okay. So what are the timelines to start thyroxine? How do you follow up these patients of So you must try to start the medicine as within 2 weeks and follow up every 1 to 2 monthly. Initially 1 2 monthly, within the first 3 4 months, and after that 2 monthly, and after 1 year you can use every 3 monthly follow up in this. So this is very important to understand because it makes a lot of difference. Early diagnosed treatment to achieve good intellectual outcome. It is very, very important because basically why we're talking all this, why we're doing all this is because so this is why we're doing all this, because it gives an idea to intellectual outcome, because this is one of the conditions where you can prevent mental retardation if you start early treatment. There is no problem in the intellectual of your child after if you start within 2 weeks. That's why we are concerned about this 2 weeks. So we already talked about this cutoff. If the cord blood you can take as cutoff as 40. So T40. We just skip over this case and okay, an 8-month old girl not gaining adequate height since 3 years. The height is 105 centimeters. The weight is 25 kgs. The father's height is 175. The mother's height is 162. Mid-parental height is 162. Pubertal status pre-pubertal. And then, the baby is pre-pubertal. So there is no breast element, no axillary, and no pubic hair. How will you take this forward? So how will you manage this child? So that question comes of this. So the next question is that you see here. Now in this child, the hemogram was done. See, again, taking the baby. The baby's height is 105, very less. The weight is okay. Father's height 160 is very short for a height. So taking this as a growth chart, we were trying to see hemoglobin is within normal, LFT is normal, KFT normal. TT is negative. We're trying to find out what are the other causes height to become short. So all hemoglobin is normal, liver function, kidney function, or B-Raji test run. Even if we have ruled out tired ruled out Turner syndrome is good, and it is normal. Karyotype is 46XX. So this way, this all the other causes shorts is out. So then what was done for this? It was plotted. So when she was plotted on the growth chart, you can see here that she's short. She's weight. So weight is on the 25th percentile, the weight is on the 25th centile, and the height is much more below the third centile. So therefore, she is short and plummy. So what was done was the growth chart plotting was done, and this was the heightage and weightage was calculated. So the heightage was very less, the weightage was more, and this was very short. So this is likely to be a case of, so you have a chronological age more than weightage more than heightage. So FT4 was very, very less. THS 250. So this girl of short stature was a case of was a case of acquired hypothyroidism, and she was treated with thyroxine, and dramatic improvement was there, and she started growing. So you must remember that for acquired hypothyroidism, the pointer of diagnosis is delayed dentation. If a child has delayed dentation, yes. If the child is growth retardation, think of acquired hypothyroidism. If the child is complaining कि मुझे ठंड ज़्यादा लगती है, I'm feeling very cold and all that, intolerance is there then. If the child has chronic constipation, then you think of it. If the child has precocious puberty with growth retardation, it's one of the only cause of where a child can have growth retardation precautionary. Otherwise, all children with precocious puberty will be tall. So it's the only condition where you have a short child and who already entering puberty, who's having breast development and who might get menarche also. Chronic urticaria. I'll just tell you, we had a one child, be seen by a dermatologist, getting medicine, urticaria not improving. Just ask them to get a thyroid function test with that. TSS were around 200. When the child was started on thyroxine, immediately improved all the rashes, everything disappeared. So proximal myopathy also. So examination, you might have child with bradycardia with narrow pulse pressure. You may get pseudohypertrophy of calf muscle. You may get macroorchitism. So this can also be seen, in children with this. So the basic is that you can have all these, and you may have galactorrhea. Sometimes secretion for the breast can occur, and along with that papilloma and KSM. So this is a last case we're going to talk, and then after that we're going to close up. When we have a next time another session, a 11-year-old with known case of bronchial asthma is admitted with acute examination. So this child has respirator 132, pulse rate of 132, respirator 36. Central cyanosis, tremor, there are no answers. She's sweating a lot. She's wheezing on chest auscultation. She's managed with bronchodilators and methylprednisolone. The doctor got her thyroid function test. I don't know why he got it done, but it was done. FT3 was 3.13, FT for 1, TSH was 0.2. So he thought this is thyrotoxicosis because TSH was very low. So then he would change the most common cause as he said the thyroidostorm, steroid. So basically steroid causes THS suppression. So this guy was given methylprednisolone, this child, and because of that, TH got suppressed. So that is why you have the values of FT4 normal, FT3 normal, THS suppressed. This is basically, it could be a non-thyroid illness. I told Lord can present anyway, and or it could be safe. So therefore, this patient was a case of steroid-induced TH suppression and not thyroid. So TSH is low in non-thyroid and drugs such as PTU, dexamethasone, propanol, or metronidazole. So there's another case. A 16-year-old girl with irregular cycles, 5 cycles a year, visited gynecologist and was diagnosed PCOD. BMI was 29, managed with lifestyle management, OCB and metformin for a year, referred for weight gain, did thyroid function test, 8.4, T31. So thyroid T4 was 8.4, T31 is good, TS is 8.2. TS was slightly raised. So what is this? Is it hypothyroidism? Is it subclinic hypothyroidism? PCOS only constant. So in this girl is taking, she's taking oral contraceptives. Oral contraceptives, estrogen. Estrogen will always increase the TBG. So because of increase of the TBG, so therefore the thyroxine which is there present is becomes less. So what happens is the TSH increases to increase the T4 and T5, FT4, because a lot of it's going to bound to the T4, less will be available in the blood. So therefore, this is basically just subclinic hypothyroidism due to increased TBG. So this is So this thyroid function is altered because of oral contraceptives. So you have to keep this in mind. There may be some drug which may interfere with the thyroid function test and maybe causing this. So keep that in mind whenever you're doing this. So I think we will wrap up now, and we'll have next after, maybe the next time we can have more cases and also more discussion on thyroid disorders in children. So thank you very much for your everybody. I mean, for your this thing consideration, and I hope it makes it is helpful to most of the doctors in the day-to-day practice when they're dealing with thyroid disorders in children. Thank you very much. I just forgot to introduce. I'm Dr. IPS Kocher. I'm a senior consultant pediatric and adolescent endocrinologist at Indraprastha Apollo Hospital.
Hello.
Hello.
Yeah, there are some questions also now. So I will be
Yeah, we
sharing
can have the
one by
question.
one.
We can have the questions.
Yeah. I have posted the first question.
I can't see any question.
Okay,
So
I will.
you just tell me what is the question.
Yeah, yeah.
I will
The
answer.
question is, what is the role of radioactive iodine thyroid scanning in the diagnosis of thyroiditis in children?
Okay. So basically, radioactive iodine is now not being used much. Now we're using technetium scan, 99 technetium scan. We can use radioactive 131 also. But the advantage is that, patients who have thyroiditis versus patients who are really having hypothyroidism or thyrotoxicosis. In thyroiditis, there is no uptake of the radioactive iodine or the technetium, 99 technetium. So therefore, you can know that this patient may have deranged value, may have low TSH, may have high FT4. But when you do a scan or when you do radioactive iodine, it will help you in differentiating between thyroiditis and actually grave disease or an Hashimoto this thing thyroiditis. So therefore, this is a very important tool for differentiating between thyroid, because in thyroiditis you don't need any treatment. It is self-limiting. Where in cases of hyperthyroid, if it is grave disease hyperthyroid, which is shown in radioactive iodine or on your scan, you need to treat it. It will be long-term treatment. You need to give antithyroid drugs like neomercazole or along with propanol or something else. Lugol's iodine may have to be given.
The next question is, how are infants with chronic autoimmune thyroiditis monitored?
So it's like this. It depends upon the age. If the child is 2 years, so what we do is we do FT4 TSH and repeat it after 3 months and see when once the level, and you must remember that. So you after maybe 3 months, you call this child, you find that still the TSH on the higher side. So you just increase the dose by 12.5. See, in children, you always try to be slow and increase in dose. And only the two conditions where you have to be aggressive is newborns and in pregnancy. The rest is all stored. So you try to increase the dose slightly by 12.5, 25, and call the baby back after 6 weeks till this DHS and FT4 come back to normal. So initially, you have to every 6 weeks call them till you're till you're increasing the dose. Once you have stabilized the baby and your THS FT4 is normal, then you can call 3 monthly in the first year and then after 6 months.
Next question is, which medications in the drug class hormones are used in the treatment of thyroiditis in children?
Which what?
Which medications in the drug class hormones are used in the treatment of thyroiditis in children?
No, I didn't get your question. Thyroiditis in children, what is happening?
Which medications in
Uh-huh.
the drug class hormones are used in the treatment of thyroiditis in children?
So there is a different types of thyroiditis, subacute thyroiditis. These they're just anti-inflammatory drugs. There is no thyroxine. Thyroxine is only used for hyperthyroidism. That's all. So thyroiditis and hypothyroid two different conditions. So if you have a subacute thyroiditis, you don't need to do anything. You don't have to treat that patient. You just have to give anti-inflammatory drugs, and maybe if an infection is a cause, you treat the infection. That's all. So thyroiditis treatment will not be related to any hyper. It's just that you have to treat an inflammation. It's a basic inflammation of thyroid gland. So the inflammation of thyroid gland is anti-inflammatory drugs and antibiotic will cause the infection. Sometimes you have thyroiditis because of sending infection throat or maybe somewhere lymph node that will cause thyroid.
And the last question, what is the role of fine needle aspiration in the diagnosis of thyroiditis in children?
What is the role of?
Fine needle aspiration in the
No, no. So yeah. So you see, we do not do fine needle aspiration in children very often. So FNAC is only done if you're suspecting a nodule. We have picked up a nodule in ultrasound. So ultrasound is one, modality which we use to do pick up, these children with nodules. And then if they have a nodule, then only we do an FNAC. Otherwise, we are not doing any routine for any child FNAC for thyroiditis or hypothyroidism, unless there is a goiter with nodules or there is a single nodule, because malignancy is much more common in children as compared to the adults. So we take a biopsy from that. That means FNAC is done, and with FNAC is done with that. Otherwise, routinely we are not doing FNAC for any of the children. If there is a patient hypothyroid, he may be having a hot nodule coordinate that can be picked up with a scan. So FNAC is not done in children unless you have evidence by an ultrasound of a nodule, or you have multinodular goiter is there in that child, which is very, very uncommon at this childhood age or till the age of 16. How do you see any patient multinodular goiter?
Yeah, we are done with all the questions. And thank you very much for your valuable time, sir, and sharing important insights on the topic.
Okay. So thank you very much. Thanks everyone for joining in and making it interactive. So thanks. Hopefully we'll have another session on thyroid, and then let's see in the future.
Okay,
Thank you
sir.
very much. Thank you
Thank
all
you.
for.
Thank you, sir. So you can stop sharing. Yeah, you can sign off now.